Interest avutadena. Darlo open nearly AC ಬಂದ್ ಮಾಡ್ತಿದ್ರು ನೋಡ್ರಿ.
AC ಬಂದ್ ಡೋರ್ ಹಾಕ್ತಾರೆ.
Good morning to all. How are you all doing?
Good morning, ma'am.
Good morning. I hope all of you are in very good health and doing very good in academics also. And the result of first internal assessment MCQ test is 100%, is it not? And many of you have scored very good marks of distinction level, and hope you are all doing academically also very good. We are happy about that. Okay, so let us continue with the further part of the gastrointestinal tract today. I'm going to deal with pancreas. What is pancreatic gland and what are the secretions it does, and what is its very pivotal role it plays in digestion of the fat especially. Second comes the proteins and carbohydrate. And we are going to see today this pancreas under these objectives. We'll study first about the functional anatomy of the pancreas and the structural characteristics, histology, physiological histology of pancreas, gland, and what is the nerve supply, blood supply, lymphatic drainage, etc. Then we will see about the pancreatic juice. We are more concentrating as a physiologist on pancreatic juice because what is the role it plays, that is going to decide the disorders it's going to cause in a human being, right? So we'll study under composition of pancreatic juice, functions of the juice, and how it is regulated physiologically. Once you understand this thoroughly, then you can understand easily about the disorders or applied aspect of the pancreatic gland. Then we'll go through quickly at the end of pancreatic function test because we are going to deal this in detail in biochemistry, and what are the most important tests we will see, and we'll end with the disorders and applied aspect. So to begin with pancreas, how or what is the physiological role of pancreas? To know this, you also need to know the clinical features of the pancreatic gland that it causes in the human being. So let us study one case problem on the disorders of pancreatic gland, wherein basically here you are going to see a 25-year-old female, especially I am quoting here female. At 25, age is important, gender is important here, and next is important is the complaint. She complains of persistent diarrhea, means diarrhea is there for her for a longer duration. Usually we'll have a diarrhea anybody has will end by 2 days maximum. After taking some medication, it will end by 3 or 4 days. But she complains of persistent diarrhea, a very important clinical feature, and a steatorrhea, which exactly tells steatorrhea. The word meaning is fatty stools, where it consists of a huge bulk of fat in the feces. So, and along with that, she also complains of abdominal pain. And this pain, if you examine the patient, she will typically show pain at the epigastric region, and which radiates sometimes to the back of the renal site, back of the this side of the spinal cord. So abdominal pain and diarrhea and the steatorrhea. These are her basic complaints. No fever, no vomiting, right? So if such a patient comes with the complaints, then how you should go about? First thought should come to you that there must be some problem in her pancreas, right? Because she is not having fever, vomiting, or any other swelling or abscess, anything like that. She is complaining only of diarrhea, and fatty stool is a hallmark, we tell, which points exactly towards the pancreas, then the abdominal pain. So once you ask her to go for the investigation, radiological investigation, a series, they found that there was a growth or tumor beneath the stomach in the radiology, that ultrasound or CT scan. Then after investigation of the blood, they found there is increase in the serum amylase level, right? So after reading this case problem, then you will have a question: what is the probable cause of her symptoms and what dietary restrictions are needed for such patient? Now, what is her probable cause? One of the probable cause I told may be the pancreatic problem. Second will be bile salts or jaundice or liver problem, right? Both are dealing with the basically with digestion of fat. So if fat is not digested, then that's why there is a foul smelling, bulky fecal matter containing fat is called as steatorrhea, will be the main complaint. So probable cause may be pancreatitis, chronic pancreatitis, and the dietary restrictions you have to advise for such patients is lower intake of fat, right? Or almost nil intake of fat, and more intake of carbohydrates and proteins. Okay, so this is the case problem. You have seen what will be the main causes of the patient having pancreatitis. Now we'll see the physiological basis of this. So just to go through briefly about functional anatomy, you already know, you must have studied in +2 also. Pancreas is an elongated accessory gland, sometimes it's called as, situated retroperitoneally, and the position of this gland is transversely placed at the posterior part of the stomach or abdominal wall. It is resting, wherein duodenum is on the right side of the pancreas and spleen is present on the left side. Now, anatomically, there are 4 parts of pancreas. You know, you are going to study this in detail in anatomy, so I am not going to highlight more: head, neck, body and tail. But we are interested in physiological classification, that is exocrine and endocrine part. You should remember, pancreas is only one organ in our body wherein it secretes both, or it is having cells that are both exocrine and endocrine. Now you know exocrine part secretes pancreatic juice, whereas endocrine part secretes glucagon, insulin and somatostatin, right? So we are dealing today only with the exocrine part of the pancreas. So now just to make you realize that when you see the histology of pancreas, here you can see the duct cells, that the duct cells are the cells which line only the ducts of the pancreas. Intralobular and interlobar ducts are there. These are going to secrete only aqueous part of the pancreatic juice. Now this is very important. You are going to read everything in the textbook, but what you need to understand and remember in this is the enzymatic part of pancreatic juice is different from the aqueous part of pancreatic juice, right? But the pancreatic juice is overall combination of both enzyme and aqueous, but the secretion part is different. So which cells secrete the aqueous part of pancreatic juice are the columnar epithelial cells that line this ductal portion of the gland, whereas the acinar cells, which are present mostly at the apical part of this acini of the pancreas, they secrete the enzymes. Okay, so now you remember enzymes are secreted by acinar cells and stored in the zymogen granules that are present inside this acinar cells, whereas the ductal columnar epithelial cells secrete the aqueous part. Now this is very important because in detail when we see about the composition of pancreatic juice, you are going to know that the concentration of the cations and anions vary drastically in the aqueous form of the pancreatic juice. Okay, so these, apart from the exocrine part, you are going to see the histologically in the pancreatic gland, the endocrine part of the pancreas, that is mostly known as islets of Langerhans, which secrete the hormones like this. Okay, so here you are going to see the blood supply and this also. Now coming to the acinar cells. Now let me tell you, the gland of exocrine part of the pancreas resembles very much like the salivary gland. Okay, structurally, histologically. So like that, the acini are present in the salivary gland also. So the acini are present in the exocrine part of pancreas also. So these acini contain the various acinar cells which are pyramidal in shape, and they contain they are loaded with this endoplasmic reticulum, mitochondria and Golgi bodies, because the main function of acinar cell is to secrete the enzymes. And lot of enzymes are secreted in pancreatic juice. There is a list of enzymes, we'll go through that. So because heavily this is acinar cell is loaded with zymogen granules, right? Now these zymogen granules are the storage granules. These enzymes are synthesized and stored in the zymogen granules in the acinar cells. Whenever the stimulus occurs, like a lot of consumption of fats or proteins occurs, then these glands are stimulated and they release their content of enzymes into the ducts, right? Now you can see here when the stimulus occurs, they will release zymogen granules, release the enzymatic content, but these enzymes are always in inactive form. This is another important characteristic of pancreatic juice. No enzyme is in the active form when it is getting released from zymogen granule into the ductal part, right? Because these inactive enzymes are getting converted into active form in the ducts only, not in the acinar cells. Okay, this is second important characteristic feature you should remember. Then this bicarbonate and chloride exchange occurs, and this especially occurs in the columnar cells, the aqueous portion of pancreatic juice that is secreted from columnar cells lining this duct part. Okay, so you remember acinar cells are there with the heavily loaded zymogen granules. They release the enzymes, stored enzymes in the inactive form in the interlobar ducts, and then the bicarbonate and others are secreted later part. So this is the basic structure of the acini. Then here you can see again this endocrine part of the pancreas, wherein you can see these are pancreatic acini. In between the pancreatic acini, central portion is having the endocrine part, where is this islets of Langerhans are there, delta cells, alpha cells are there, which secrete glucagon, insulin and somatostatin like that. Even some few red blood cells and beta cells you can see when you go through the histological part. Now these acinar cells are lining the alveoli. I told you they are in pyramidal shape or triangular shape of these acini cells, and zymogen are secretory granules that are present inside them, and they release inactive enzymes, and the ductal system of pancreas is very much well developed, because the columnar epithelial cells that are lining these various ducts secrete aqueous portion, and this aqueous portion of pancreatic juice goes on changing from the primary secretion to the till it is released into the main pancreatic duct. Okay, so pancreatic duct system, when we study, first it is intercalated ducts. Intercalated ducts are just inside the, if you remember this diagram, these are intercalated discs. They combine to form this interlobular ducts. Means intercalated ducts collects the enzymes from the acini and drains into the interlobular ducts, and these many interlobular ducts, they join to form the main pancreatic duct. Now you see this is a main pancreatic duct, extends from tail to the head portion, and this is going to receive many tributaries along its journey from tail to the head portion or neck portion, and all interlobular ducts join to the main duct and drain into this main duct. Now, wherein this main duct joins with the biliary duct, biliary duct, and it forms a ampulla, and this together both join and drain into second part of the duodenum called as ampulla of Vater, and this ampulla of Vater is, or it's also called as major duodenal papillae, is guarded by a sphincter called as sphincter of Oddi. So sphincter of Oddi and is a name of again a scientist who invented this sphincter and explained about the physiological functions of it. So you can, apart from this, you can see the how the cystic duct arising from the gallbladder joins the main pancreatic duct, and both together they empty into the major duodenal papillae, forming a sphincter of Oddi, right? So there is one more accessory pancreatic duct. This is central one is the main duct which extends from the tail to this head, wherein CBD joins this common bile duct and both together drain here into the major duodenal papilla. And in some people, accessory duct also arises from this main duct, but it drains the only head portion of the pancreas, and it opens into the first part of duodenum. That is also called as minor duodenal papillae. Now you should remember the variation of this, because these major duodenal papillae and minor duodenal papillae, which drain both major pancreatic duct and accessory pancreatic duct, plays an important role in prevention of development of duodenal ulcer, right? Duodenal ulcer. If you remember, duodenal ulcer will never form in the second part of the duodenum. It's found most of the time in the first part of duodenum. Now, what is the cause? Because every person don't have accessory pancreatic duct, right? So the role of pancreatic duct is to drain the pancreatic juice. Okay. Now this pancreatic juice is very much rich in bicarbonate. Now this bicarbonate with alkaline pH will neutralize the acidic chyme that enters from the stomach. Now because common bile duct, pancreatic duct, main duct, both together open in second part of duodenum, so the neutralization of acidic chyme takes place immediately, and that's why this site is likely to develop the duodenal ulcer, right? But the first part of duodenum does not receive every time drainage of this accessory pancreatic duct juice. So the neutralization of acidic chyme is likely to occur in the first part. So many people develop the duodenal ulcer in the first part of duodenum, not or never or very rarely in the second part of duodenum. Okay, so I have told you what is the cause for not developing duodenal ulcer in the second part of duodenum, and why the first part of duodenum is more prone for development of duodenal ulcer. Okay, fine. Now we'll move towards the main pancreatic duct. Now again, I have put this diagram everywhere because it's very important physiologically to know that there is a main pancreatic duct and an accessory pancreatic duct sometimes in few people. Now main pancreatic duct is called as duct of Wilson, goes by the name of scientist, whereas accessory pancreatic duct is called as duct of Santorini, and this opens in the first part of duodenum in minor duodenal papillae, whereas main duct opens in the major duodenal papillae, that is duct of Wilson, along with the common bile duct, and this is guarded by sphincter of OD. There is no sphincter in the accessory gland. So only one point I would like to highlight is the main, that is duct of Wilson, drains whole part, tail and body, almost few part of head, pancreatic juice into the ampulla of Vater, whereas accessory duct drains only the upper part of the head of pancreas, right? And opens into first part of duodenum, whereas this opens into second part of duodenum. Okay, so it's now clear what is duct of Wilson, what is duct of Santorini, and which part of pancreas they drain into which part of duodenum, and why duodenal ulcer doesn't develop in second part of duodenum. Okay, this much is clear for you. I hope this is clear. All of you are there or just kept for recording and gone away?
Oh, ma'am.
Yes, ma'am.
Okay, fine. It is clear now?
Yes, ma'am.
Oh. So we'll go to the next part of pancreas, that is what is the blood supply and venous supply and lymphatic drainage and nerve supply. Now this is only physiologically I am touching. This is important for us to know the drainage of this. So the main arterial supply for spleen is splenic and pancreaticoduodenal arteries that gives many branches to this pancreas, and veins, the corresponding veins, that is splenic and pancreaticoduodenal vein, drains ultimately into the portal vein. Lymphatics basic drainage of pancreas is into the cealic and superior mesenteric lymph nodes. Means if cancer, acute pancreatitis or CA pancreas occurs, these are the lymph nodes that are basically enlarged. Okay, cealic and superior mesenteric lymph nodes. Then coming to the nerve supply is important for us to understand the regulation of pancreatic juice. Okay, so basically you know that vagus parasympathetic nerve is the main nerve that supplies the whole GIT tract. Here also it plays a dominant role, whereas stimulation of vagus nerve causes huge secretion or increase in the secretion of pancreatic juice, whereas sympathetic nerve also supplies pancreas, but stimulation of sympathetic postganglionic neurons causes reduction in the synthesis of the pancreatic juice. Now this vagus nerve innervate both acinar and smooth muscles of the ductal cells. That's why whenever there is stimulation, it will increase the synthesis of pancreatic juice. Okay. Now this is again just to repeat the anatomical part, that this cystic duct, this transversely lying pancreas, and this is the main duct which opens into the duodenal major papilla, that is ampulla of Vater. It's called as guarded by sphincter of OD. And this is minor duodenal papilla where accessory gland of pancreas opens right into the first part. This is into the second part. Okay. Now coming to physiological main part, that is pancreatic juice. Now you must remember there are few characteristic features of pancreatic juice which I have already told, right? And now coming in detail, the properties of pancreatic juice. Any juice or any secretion we study in gastrointestinal tract, you must first remember the properties, because they are specific to that juice only. So for pancreatic juice, the specific properties are: first, it is a transparent, clear juice, means there is no color, but the composition is almost isotonic with plasma, right? Composition is isotonic with plasma, means most of the concentration of pancreatic juice is similar to the plasma. Now total content secretion is 1 to 1.5 liters per day, right? Then the specific gravity of pancreatic juice ranges from 1.010 to 1.018. Now remember, if a question is asked, like describe or discuss the pancreatic juice, its composition and regulation, whenever you write the composition of any juice, first these points must come: its color, right, its tonicity, and how much quantity of the juice is secreted per day, and what is the specific gravity of the juice, and what is the pH of that juice. Whether you explain the gastric juice, saliva, or pancreatic juice or intestinal juice, all these secretions must contain initially the properties is very important to quote, right? Then you can go for detailed composition. Okay, so specific gravity, and the most important point for pancreatic juice is its alkalinity. Now you can see the pH of pancreatic juice is 7.4 to 8.4. This is the most alkaline juice in the body, whole GIT tract secreted. Whereas, see, it is exactly opposite to the gastric juice. If you remember gastric juice, what is the pH of gastric juice? Anyone can tell me?
1.5 to 3.5.
Yes, it is highly acidic, right? So highly acidic, so almost 2 to 3 like range we can give. So 1 also, if you go deeper into the gastric glands, then it is 1. As the juice comes up about to the mucosal level, it may reach to 3. Okay, so that much of highly acidic gastric juice has to be neutralized. Otherwise, what happens? That will digest the duodenal mucosa also, and it is going to damage and cause a duodenal ulcer. That's why to neutralize the high acidic chyme that enters from the stomach, the pancreatic juice possesses a very high alkalinity, and this alkalinity is because of highest concentration of bicarbonate it is having in this. So how much is concentration? We tell it is isotonic with plasma, but whenever the stimulus occurs for secretion of pancreatic juice, this bicarbonate concentration increases almost 4 to 5 times of the plasma. Means whenever the acidic chyme enters from the stomach to the first part of duodenum, this stimulation increases this. Okay, so whenever you tell what is the special feature of pancreatic juice, the first answer should come the pH, right? So if imagine if this doesn't happen, then whole of the duodenum will have duodenal ulcers only, right? So one of the important property of pancreatic juice is its alkaline pH ranging from 7.4 to 8.4, and this is because of highest concentration of bicarbonate. Okay, then now this is the detailed composition I have just put. Now you know every juice contains 99.5% of water and solids are only 0.5%. Here 2% will be the enzymes. So we divide pancreatic juice further into aqueous part and enzymatic part. As I told you, aqueous part is secreted from the columnar epithelium of the ductal cells, whereas enzymatic part is secreted from the acinar cells. So these organic and inorganic substances remain common. So inorganic substances include cation and anions. In cation you will have sodium, potassium, calcium, magnesium, zinc, right? Whereas anions here are basically bicarbonate and chloride, phosphate and sulfate, right? So cations and anions form the inorganic substance. The organic substances are further always divided into enzymes and other organic substance. Now other here are very minor in quantity like albumin and globulin, whereas the enzymes are very important in pancreatic juice, right? So these enzymes are further divided into three types. One is proteolytic enzymes, means that are strictly limited to digestion of proteins only, and next is important lipolytic enzymes. But I put in other way, the pancreatic juice is the one which is depends basically on the digestion of the lipids. So lipolytic enzymes are the comes in the first position, second is proteolytic enzyme, last is the amylolytic enzyme, because if you remember, the gastric juice basically concentrates on the digestion of carbohydrates and very limited proteins and fats, whereas pancreatic juice concentrate basically on the digestion of the lipids and proteins, and last is the carbohydrate. So this is the second important difference you must remember. The first is its alkalinity, second is its lipolytic enzymes, exclusively lipolytic enzymes, because maximum amount of the digestion of fat takes place with along with bile juice, right? If you remember, the common bile duct drains in both combined pancreatic duct and common bile duct combined together, and the secretion what comes out into the ampulla of water is the one which helps in the digestion of the lipids. So lipolytic enzymes, there are six. The first is pancreatic lipase, cholesterol ester hydrolase, phospholipase A and B, and co-lipase, and last is the bile salts that are activated by these lipases. Pancreatic lipase activates bile salts also, which helps in the emulsification of the fat. So second is proteolytic enzymes. Now these are trypsin. A most potent proteolytic enzyme is trypsin. Remember, so trypsin, chymotrypsin, carboxypeptidase A and B, these receptors, then nuclease, elastase and collagenase. So you can see the names of each of the enzyme tells you which part of protein it is going to digest. Okay, so trypsin and chymotrypsin are okay. They are going to digest the large amount, this long chain amino acids, whereas carboxypeptidase acts specifically on the only carboxyl group. Nuclease are acting specifically only on RNA and DNA. Elastase acts only on elastic fiber, and collagenase acts exclusively on collagenase digestion. So the names are very specific, and there should not be any confusion in remembering these six proteolytic enzymes. And in similar ways, the six lipolytic enzymes also you have to remember that, because pancreatic juice is the one which after this only intestinal juice comes, and that is the last part of digestion and absorption. Okay. So amylolytic enzyme, third enzyme group is amylolytic enzyme. This is having only pancreatic amylase. Then we will see what are the, this is a minor, so only one enzyme for carbohydrate digestion, whereas six enzymes are there for lipid and proteolytic enzymes. Now bicarbonate content of this pancreatic juice, I told you, is the highest 4 to 5 times of the plasma, and that's why almost 110 to 150 milliequivalents per liter. Now that highlights its function. Now coming to pancreatic amylase, it digests carbohydrates basically. In its active form, it acts on carbohydrate like salivary amylase and digests the, and it hydrolyzes the glycogen and starch, but it will not act on cellulose. So except cellulose, it has its action on glycogen and starch. Now coming to lipases, pancreatic lipases is a group of enzymes where it acts, I told you, is exclusively on lipids, and Of this, pancreatic lipase, cholesterol ester hydrolase, and phospholipase A2 are very important. Now, pancreatic lipase. See, if you get a long question on pancreatic juice, you have to explain 1 or 2 lines about each of the enzyme, right? Just naming the enzymes is also okay, but if you can highlight the action of each of the enzyme is well and good for distinction marks. Then, hydrolysis, pancreatic lipase acts exclusively on neutral fats. It digests into glycerol and free fatty acids, esters, whereas cholesterol ester hydrolase, it acts only on cholesterol esters to form a cholesterol. Then phospholipase A2, it acts on phospholipases to get it converted into lysolecithin and lysocephalin to ultimately end product is phosphorylcholine. Now, if you study the biochemistry of these, you will find these enzymes are very important, and these end products what they are secreting is equally very important. Phosphorylcholine. Okay. Then coming to pancreatic proteases, this proteins enzymes of pancreas are divided into 3 endopeptidase are there and 2 exopeptidase. Endopeptidase and exopeptidase they are divided into. Now endopeptidase are, what are the 3 endopeptidase? They are trypsin, chymotrypsin and elastase, whereas 2 exopeptidase are carboxypeptidase A and B. Okay, so you remember there are totally 5, means important, there we had seen the 6th one. Now last one is trypsin inhibitor, another very important enzyme which inhibits the trypsin function, because trypsin, I told you, it's a potent proteolytic enzyme. It's like a double-edged sword, right? Why it's called as double-edged sword? Because of its potent proteolytic property, if trypsin is not restricted by its action, it will digest whole pancreas only. That is called as autodigestion, right? Which happens in acute pancreatitis, right? So now you have to think that then why normal persons this trypsin is not going to digest the normal acinar cells of pancreas, because first cause is all these proteolytic enzymes are secreted in the inactive form. Okay, if you remember my diagram which I shown initially, they are not released as a active enzymes. They are all in their inactive form. That's one of the reason why the trypsin is not digesting its own or pancreatic cells. Second important cause is presence of trypsin inhibitor enzyme. Now it always regulates or controls the action of trypsin. Whenever how much action is required of trypsin, that much action only will occur. The excess action is suppressed by this inhibitor. Suppose if trypsin inhibitor is not present or secreted in lesser amount, as it happens in acute pancreatitis, there will be necrosis of the pancreatic tissue, and that we call it as acute condition. Acute pancreatitis will lead to necrotizing pancreatitis, right? So that is because trypsin inhibitor is deficient. Okay, so that is the role of trypsin inhibitor. Now we'll see quickly. You all know these trypsinogen, these are the inactive forms of this protein enzymes, and they become active in the ductal portion, okay, not in the acinar cell. So in ductal portion, the main activating mediator is enterokinase or endopeptidase, which is present in the duodenal mucosa, converts this inactive form into active form. Once this trypsin is formed, it causes autocatalytic reaction. It starts activating all other enzymes also, right? So trypsinogen is autocatalytic reaction. Auto means self, activation. It forms a trypsin. So like this, all the enzymes are getting, then lipases all will get activated because of only the presence of trypsin itself. And these both trypsin and chymotrypsin together, they will hydrolyze proteins to proteoses, and ultimately end product is polypeptides. Okay. Now these polypeptides in turn will be further digested into breaking down into amino acids in the intestinal juice. Okay. Then this is again a diagram showing inactive form of trypsinogen, procarboxypeptidase, chymotrypsinogen. These are all inactive form. They are getting activated into trypsin, carboxypeptidase and chymotrypsin in the lumen of the duodenum with the help of the endopeptidase, and then trypsin only will autocatalytic action. Okay. I think this much is clear. Then chymotrypsinogen is getting converted into active form chymotrypsin with the help of trypsin. Then proelastase is which is going to digest only elastin, is again activated by the presence of trypsin. And carboxypeptidase A and B, they are also activated by trypsin. I told you once trypsin is formed, then it will further automatically starts activating all other enzymes. It cleaves only carboxyl amino terminal. Then I have highlighted here again the role of trypsin inhibitor. This inhibitor is very important because it protects the pancreas from autodigestion. I told you because of deficiency of this trypsin inhibitor in acute pancreatitis, they will go for necrotizing pancreatitis. Then the enzyme nucleases, this is again activated by the trypsin, wherein it will act on nucleic acids breaking down into nucleotides, and collagenase is again activated by trypsin, acts on collagen tissue. So those are the functions and composition of pancreatic juice. Now we'll see what are the other pancreatic juice function. Basically the pancreatic juice digests the fats, proteins, carbohydrates and nucleic acid. So the digestion is one of the first function. Now the next function is neutralizing. So whenever either in Viva or theory exam, we ask the discussion of functions of pancreatic juice, you have to first tell it is having two, divide the function into two parts like digestive function and neutralizing function. In neutralizing, as you know, acidic chyme entering from the stomach will be neutralized by the bicarbonate or alkaline pancreatic juice, you can tell. Now this is a mechanism of pancreatic secretion. I will not go into the detail of this mechanism, how it happens, but I will definitely tell what is this mechanism of pancreatic secretion. So you know the enzymes are secreted from the acinar cells, okay? Then aqueous component is secreted from these ductal cells by the columnar epithelium. Now this is mechanism of HCO3 secretion is similar to that what you have seen in the HCl secretion of gastric juice. So carbonic anhydrase enzyme mediates water and carbon dioxide to form HCO3, and in the same way. So now we will see the acinar cells which secrete only enzymatic is isotonic, and it exactly resembles the composition of plasma, whereas secretion by interlobular ductal cells means aqueous portion of pancreatic juice is hypertonic to plasma, right? The isotonic is only acinar cell composition, whereas hypertonic is the intralobular, that aqueous portion, because it's having high concentration of bicarbonate and potassium. Now secretion by extralobular ductal cells. Now these are the intralobular duct, these are the extralobular duct. They are actually extralobular duct does not secrete the aqueous portion unless it gets stimulated by the hormones, GI hormone secretin, and this once it is getting stimulated by secretin, it is going to produce a very highly rich bicarbonate aqueous solution. Okay, so there will be modification. If you see these two, intralobular and extralobular, you will see there is a modification in the main duct, collecting duct, as the aqueous portion of pancreatic juice moves, right, in the main duct, right. So if you remember, these two are secreting hypertonic solution rich in chloride and bicarbonate, okay, aqueous pancreatic juice. As this aqueous pancreatic juice moves in the main duct, there will be addition of water, right, and it moves out, and some chloride moves outside and enters inside, and bicarbonate moves outside. And that's why this diagram will show you how the modification of pancreatic juice occurs as it travels from the tip to the main duct, right. So sodium chloride and water and chloride are very rich in the initial part, that is primary fluid it is called. As it moves into the duct, pancreatic duct, there will be addition of chloride and water, so it becomes diluted here, okay. Then bicarbonate ions are directly proportional to the rate of concentration of secretion of pancreatic juice. Means at resting state of pancreatic juice secretion, bicarbonates are only 80 to 120 milliequivalents. I think someone's mic is unmuted. Can you please mute your mic? Who is there? Can you mute your mic? Yeah, okay. Over. Okay, is my slides are visible?
Yes, ma'am.
Yes, ma'am.
Oh. So this diagram shows the rate of concentration of bicarbonate and chloride as it moves from the initial portion to the towards the main duct. So if you see, the bicarbonate concentration goes on increasing as the rate of secretion of this pancreatic juice increases. This is the resting state. During resting state, the chloride concentration is highest, but bicarbonate is lowest. But as the rate of flow rate increases, there will be increase in bicarbonate concentration and decrease in the chloride concentration. Okay. So this is the graph which tells you there is a modification in the secretion of pancreatic juice along with the flow rate. Okay, now this again depicts the same picture, but if you remember, sodium and potassium remains constant, right? Here cations remains constant irrespective of flow rate of pancreatic juice. Now whereas bicarbonate and chloride ions concentration changes as the flow rate of pancreatic juice increases, right? So bicarbonate becomes 10 to 15 times more than plasma, chloride becomes 10 to 20 times less than plasma. Now this is for distinction students. See, when you people are not responding, you can unmute your mic. Okay. So these two slides which I told you, flow rate of pancreatic juice decides the concentration of bicarbonate and chloride is for distinction students. It's not for average students, right? So again, this diagram again tells that here how the concentration of bicarbonate becomes 140 milliequivalents and chloride becomes 110 as it moves from acinar cells into the ampulla of Vater. Okay. Now coming to quickly the regulation of pancreatic secretion. So regulation is by both neural and hormonal. Neural is through vagus, which supplies the exocrine part of pancreas, whereas hormonal is through secretin and CCK, mainly gastrin and somatostatin also acts. So this picture tells you whenever there is entry of acidic chyme that is entering into the duodenum, what happens? Secretin released into the bloodstream from the intestinal mucosa, and that in turn stimulates the pancreas to secrete these enzymes, and pancreas secretes the juice, and this juice is very much rich. See, whenever the secretin causes the pancreatic juice rich in bicarbonate and the acidic chyme is neutralized. So we will study this regulation under the different phases. Now, if you remember the gastric juice secretion in 3 phases, similar way, pancreatic juice is also secreted in 3 phases: cephalic phase, gastric phase, and intestinal phase. In cephalic phase, if you remember, the stimulus is only the taste, smell, thought of food or chewing. The mediator here is vagus, which causes pancreatic. Response is enzyme-rich pancreas secretion. Whereas in gastric phase, the stimulus is distension of gastric mucosa. Mediator here is vagus nerve and gastrin. Here again the rich enzymatic secretion of bicarbonate occurs, right? Whereas in intestinal phase, the stimulus is amino acid or peptide or chyme entering into the duodenum is the stimulus. Mediator here is CCK, secretin, and through vagus also. The result is pancreatic response in intestinal phase is pancreatic juice rich in enzyme and bicarbonate. So again this tells you the same, okay. I don't want to highlight this again and again. Now role of secretin, I'll just tell you, it is getting stimulated whenever pH of chyme is less, that is when it is 4.5, means acidic chyme as it enters into the stomach, it contains 27 amino acids, and it helps in the secretion of highly alkaline pancreatic juice. So its main aim is to neutralize HCl, right, and stimulates also. Apart from alkaline pancreatic juice, the other functions of secretin are it stimulates bile, potentiates CCK, and it delays gastric emptying. A very important function is delaying of gastric emptying. So if you can see here, the secretin stimulation causes increase in the bicarbonate, whereas CCK stimulation causes increase in the enzymatic contents. So both together influence the pancreatic juice. So cholecystokinin is stimulated it is synthesized from eye cells present in the upper duodenum, and it is having 33 amino acids. Stimulation is fatty acids and polypeptides, and the function of CCK is it increases bile as well as pancreatic juice secretion. Tropic effect to pancreas means cholecystokinin helps in the newer functional synthesis of pancreatic cells also. Then it also inhibits the gastric motility, and another important function of cholecystokinin is it is found in the brain, where it influences the food intake and it controls anxiety and analgesia. So there are two receptors, CCK A and B. A are found in the gallbladder, pancreas and liver, whereas B receptors are found in the brain, which regulates food intake and analgesia. So this is again depicting the same regulation, how vagus nerve stimulation releases the enzymes into the acini and increases the pancreatic juice. Role of secretin and acid. Now I have put these differences between gastric and pancreatic juice. A very important viva question you should remember. The difference is gastric juice is very thin, clear, and it promotes the digestion of carbohydrates basically, whereas it is alkaline and it promotes the protein digestion. Now gastric juice is secreted by gastric glands, whereas pancreatic juice is secreted by exocrine glands. The pH of gastric juice is acidic, of course you know this. And secretion here is stimulated by gastrin, GI hormone. Here it is stimulated by secretin and pancreatinine. The main role is to digest protein. Here the main role is to digest fat and protein both. Now coming to the last part is applied aspect. There are four important disorders of pancreas. First one I have already told, acute pancreatitis, where there is acute inflammation of the pancreas, where you will find autodigestion of pancreatic tissue by the proteolytic enzyme like trypsin because of lack of trypsin inhibitor. Right, in chronic pancreatitis, there will be chronic inflammation of pancreas. This is the most common presentation, chronic pancreatitis. Then is cystic fibrosis. Another important, I will tell you what it is. Then pancreatectomy. If a person is found to have cancer of pancreas, there will be removal of pancreas. This is going to cause severe deficiency of pancreatic enzymes and malabsorption syndrome in CA pancreas patients. Now, chronic pancreatitis, as I told, it's the most common. And what are the features? There will be deficiency of pancreatic secretion. This leads to malabsorption syndrome, and because of lack of insulin, also person may develop diabetes mellitus. And the most important cause is steatorrhea. Because of pancreatic lipase deficiency, foul smelling this fecal matter is there, right? Now coming to cystic fibrosis, you will have a short answer, 3 marks question on cystic fibrosis. This is an autosomal recessive disease, mostly seen in case of children. The defect is basically in chloride channels. The gene responsible for this is mutated, and the CFTR is the which is present on chromosome number 7 is mutated. Now, the most important feature of cystic fibrosis is the affected lung, where there is decrease in the nasociliary clearance of the lung, and the fibrosis of lung tissue occurs, progresses, and person lands into intestinal obstruction and exocrine. Now, just I want the students to mute your mic because the class is for not for your parents, it is for you. I understand you are at home, but you have to give this much of time dedication to the class. Okay? So please mute your mic. So pancreatic function test, the analysis of pancreatic juice, analysis and production of digestion, and estimation of serum amylase. These are the three important tests. Now, fecal fat excretion test is important because normally 5 to 6 grams of fecal fat is excreted per day, whereas in this chronic pancreatitis, it increases to 50 gram per day. Right, almost 100%, 50 times it increases. Then there is a ceiling test. You must have heard in biochemistry where vitamin B12 absorption, trypsin helps in binding. It is done to know the absorption rate of vitamin B12 because trypsin is the hormone which mediates binding of intrinsic factor with vitamin B12, where in the absorption of B12 is regulated. So if ceiling test absorption B12 is less, that means trypsin action is hindered. So estimation of serum amylase level is another important this investigation, wherein you will come to know the pancreatitis, acute pancreatitis or cancer of pancreas. It will be 50 to 120 units per liter. Okay. Now last important newer diagnostic test for pancreas is cholangiopancreatography, wherein it's also commonly called as ERCP. ERCP is endoscopic retrograde cholangiopancreatography, right? ERCP. What it is? It's a special radio diagnostic investigation where you are going to do the detailed counters of hepatobiliary duct is visualized, and it is one of the most accurate tests. Nowadays, the facility is there for endoscopic retrograde cholangiography. So they go for this rather than other tests in case of suspected cancer, right? So that the visualization of hepatobiliary duct is done properly. So here we come to the end of this class. So by the end of the class, you must be knowing the physiological anatomy of pancreatic gland, the acinar cells, the ductal cells, columnar epithelial cells, and the aqueous solution is secreted from columnar epithelial cells, whereas enzymatic part are secreted from the acinar cells and stored in zymogen granules, and they are released in the inactive form. And next, coming to composition of pancreatic juice, proteolytic hormone enzymes, lipolytic enzymes, and carbohydrate, pancreatic amylase. Of course, the inorganic part is there. You know the cations and ions. So the most important characteristic feature of pancreatic juice is its alkalinity, the pH, which neutralizes the acidic chyme of the stomach, chyme that enters into the duodenum, and this helps in prevention of development of duodenal ulcer. Second important property of pancreas is that it is going to act basically on the lipase and the of course proteins. The deficiency or inflammation of pancreas is going to cause malabsorption syndrome, severe malabsorption syndrome, and steatorrhea. Then how the composition of pancreatic juice changes from the primary to secondary. I have told you concentration of bicarbonate and chloride keeps on changing rather than sodium and hydrogen ions. So this is and a few of the test pancreatic gland test assessment I have told you, and this is the newer ERCP also you should know. And what are the disorders of pancreas? Acute pancreatitis, chronic pancreatitis, CA pancreas, and the cystic fibrosis. So by the end of this class, you must be knowing all these things and the main important composition and function and regulation of the pancreatic juice. I hope you have understood. If any queries, you can ask. Any queries? Anybody is having any doubt? Not only the about the class, if any other thing you would like to know. No doubts. You can unmute your mic now and you can express your doubts or challenges, what you are having.
When will college start again?
We are also eagerly waiting for that. So it's will be decided by the government basically, hopefully, because cases are coming down till 7th is the lockdown or 15th. I think they have extended up to 15th June. Hopefully after June 15 we may start the college. If it comes, situation should come to normal, right?
Okay, ma'am.
Yeah. Anybody wants to ask any other queries? Okay, if no queries are there, we will leave the class. You please read now and make the notes of this so that next class I will take on intestinal juice. Okay, thank you.
Thank you, ma'am.
Thank you, ma'am.